Hello, everyone, and welcome to another episode of Heart Success Podcast. We continue our diabetes and cardiovascular disease series with a new guest and upcoming star in the field of heart failure. This interview is with Dr. Muthiah Vaduganathan, MD, MPH, who is a cardiologist at Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. Dr. Vaduganathan entered the medical field as part of Northwestern University's honors program in medical education. And through this 7-year longitudinal program, he received a bachelor's degree in biological sciences and a medical doctorate. During his time at Northwestern University in Chicago, he also earned a Master of Public Health degree and was inducted into the Alpha Omega Alpha Honor Medical Society. Subsequently, he completed his residency training in internal medicine at Massachusetts General Hospital. He is interested in drug development and clinical trials of cardiometabolic therapies. He has authored and co-authored more than 200 peer-reviewed publications in some of the top journals in the field of cardiology and heart failure, with some other thought leaders in the field. He currently serves on the editorial board of the European Journal of Heart Failure and JACC Heart Failure, including being the social media and CME editor. He is involved in an FDA think tank on improving future clinical trials in heart failure, participates as a clinical endpoints committee member for ongoing advanced phase trials in heart failure and post-MI LV dysfunction at Brigham and Women's Hospital. Welcome to Heart Success, Dr. Vaduganathan. Can I call you by your first name?
Yes, of course. Muthi would be perfect, and thank you again for hosting and having me.
Thank you. Thank you for accepting the invitation. So, as you know, we have a great talk today lined up on the overlap between diabetes and cardiovascular disease. The field has seen a lot of growth in the last few years. What about this field really drove your interest? And could you tell us, maybe our listeners, about some of the things you're actively working on?
Absolutely. You've had a really nice lineup and agenda for this session. So, really, from an epidemiological standpoint, prediabetes and obesity has increasingly become an issue in the United States, and really intersects with every level of cardiovascular disease. And for the first time, it's exciting that we have therapies that are available that can actually modify cardiovascular disease course in patients with type 2 diabetes. And it's especially striking that young and middle-aged patients who are initiated on some of these therapies may expect to actually have life prolongation if initiated early and if they remain on therapy. So these benefits are really unanticipated, and recent therapies are an important addition to the therapeutic armamentarium for both generalists and specialists. So it's just been a lot of excitement from uncovering the epidemiology to new therapies entering the market. And my specific interests relate to the complex intersection between cardiometabolic disease and heart failure.
Thanks. That's a very fast developing field. And then we're going to touch a lot of those topics today. When you're not working, when you're not in the hospital or working on research, what other interests do you go to outside of work?
Absolutely. So I'm a self-proclaimed foodie. I enjoy running. Enjoy reading. Major interests.
Yes. So as we touched upon, diabetes care is changing very fast. And as a cardiology fellow, I tried to keep up with some of the newer trials, and it was difficult. What can the primary care doctor or primary care providers, other cardiac care providers and cardiologists do to keep up with all this data that's coming out?
I share your statements. I think the pace of scientific discovery in clinical trials has been nothing short of remarkable. We've seen over 20 randomized clinical trials that have been completed in such a short duration of time. I think that as a community, we need to come together to translate some of that scientific discovery to real-time advances. Guideline committees have certainly become more and more compelled to move towards annual updates of guideline documents to keep up with the speed of science. For example, the American Diabetes Association has already adopted a living document in which they have near real-time updates after landmark clinical trials are presented. I completely agree. I think that social media does play an important role. I think especially academic Twitter allows for real-time updates regarding many of the trials and many of the science that's coming out in this field. And I think that engaging in social media can certainly help with that regard.
Mm-hmm. And your approach as a cardiologist to diabetes in your patients, are you hands-on or are you more hands-off?
Certainly hands-on. I think that more and more we're understanding that most type 2 diabetes patients that are eligible for many of these therapies actually interact primarily with primary care physicians, endocrinologists, but also cardiologists. And so I think given the number of touch points that we have in clinical care, I think it is important that we can play an important role in managing their therapies and their overall care.
Like you mentioned, this is cardiometabolic, where there's multidisciplinary involvement from endocrinologists and other care providers. Where you work right now, is there a specific structure or setup to facilitate collaboration with some of these other fields?
Yeah, so at Brigham and Women's, we're trying to engage in more collaborative care approaches. Endocrinologists are actually now physically embedded in many of our cardiology clinics to allow for real-time expedited consultation. And I think it's relevant to recognize that collaboration not only is restricted to primary care physicians and specialists or between specialists, but also involves the important central role of clinical pharmacists as well as advanced practice providers as we make a concerted effort to promote implementation of these therapies.
Mm-hmm. Some of the newer med advances, a lot of the trials you mentioned were in patients with type 2 diabetes. Do you also involve yourself in the care of some of these type 1 diabetics where the burden of cardiovascular disease is very high?
Agreed. Typically not. The overall burden of type 1 diabetes is lower across the United States and worldwide. And I think we need to be mindful that many of these therapies were actually developed in the context of type 2 diabetes, and may actually pose certain risks if initiated in an inappropriate setting in type 1 diabetes. For instance, the SGLT2 inhibitors pose some risks of euglycemic decay in the type 1 diabetic, at least more so than type 2 diabetic. Although certain SGLT2 inhibitors are approved for use in Europe in this type 1 diabetes population, it goes without saying that we need to be careful and we need to be judicious.
That's a great point. Coming back to, the intersection, like you mentioned, between heart failure and diabetes, do you suggest or recommend that we should be screening all our heart failure patients for diabetes?
Yes, this is really a critical issue. Cardiologists are certainly used to measuring metrics of renal function, lipid panels, in both ambulatory care as well as inpatient settings, but infrequently measure hemoglobin A1C in practice. And so I think screening should become a mandatory part of our daily practice. Of the 30 million Americans who live with type 2 diabetes, approximately 7 million may be undiagnosed. And if we look, we do find more disease and especially more patients that may be actually eligible for therapy. After the Affordable Care Act Medicaid expansion took place and more patients were able to be screened, especially of lower socioeconomic demographics, there was a striking rise in the number of new diagnoses of diabetes in states that had Medicaid expansion. So I think that's a real testament that when people look, they will find disease and potentially modifiable disease. So I strongly believe that at every juncture, including hospitalization for heart failure, we should screen patients for type 2 diabetes, for diabetes. And certainly this has been reflected in trials and registries when protocolized measurement of the A1C takes place amongst heart failure patients. Diabetes occurs in up to 40% of those patients.
That's true, and in some of the other conversations I've had with endocrinologists, really the focus has moved to early diagnosis and early care for these diabetic patients. From the non-endocrinologist's perspective, if I was to ask the listeners to really focus on the newer drugs which diabetic medications are we really referring to that qualifies for this newer class of medications with cardiovascular disease benefit?
Right. So there's now 12 classes of antihypoglycemic therapies available for use that are approved by the Food and Drug Administration. The newer classes certainly have been more rigorously studied in the context of cardiovascular outcome testing, and two in particular, the SGLT2 inhibitors and the GLP-1 receptor agonists, are really the first therapies to be known to modify cardiovascular disease course amongst patients with type 2 diabetes. So I think those are the classes of therapies that should become most familiar to all generalists and specialists. It is worthwhile to note that they're not overtly novel. The GLP-1 receptor agonists were introduced now about 15 years ago. The SGLT2 inhibitors were first FDA approved in 2013. So certainly we've already had several years of experience, and it's predominantly dominated by primary care physicians and endocrinologists prescribing these therapies.
Mm-hmm. I read one of your papers which used risk scores and the use of machine learning algorithms in predicting heart failure hospitalizations among patients with diabetes, the Watch Diabetes score, which involves several factors that are important, as we well know, patients with weight, age, hypertension, their creatinine, their HDL levels, their diabetes control, QRS duration, history of myocardial infarction or coronary artery bypass grafting. Could you tell us maybe a little bit about this study and how we can use this score in clinical practice for individual patients?
So thank you for referring and reading that article. So while we're really familiar with clinical risk factors associated with myocardial infarction, clinicians may be less familiar with predictors and factors that influence heart failure risk. So we asked a very simple question: which patients living with type 2 diabetes in the community should we watch for incident occurrence of heart failure? We developed a risk score using machine learning methods, leveraging data from a large randomized clinical trial of patients with high-risk type 2 diabetes who were free from heart failure at baseline. The model was derived from nearly 150 candidate variables. This model was externally validated in another large randomized clinical trial, the ALLHAP trial. The risk score really differentiated future occurrence of heart failure from 1% to nearly 20% in the top quintile over 5 years. Importantly, the novel machine learning derived risk score, WATCH-DM, relies only on clinical, laboratory, and some electrograph ECG-based variables to predict heart failure and does not require complex biomarkers.
Mm-hmm. There's another paper that I read, I believe, in JACC, which looked at the other aspect of things, where they looked at the 10-year risk equation for incident heart failure in patients with diabetes and found very similar factors really to predict the incidence of new heart failure in diabetics. So these risk factors in the WATCH-DM score seem to really work both ways in predicting risk, whether or not you have diabetes or heart failure, in predicting the other. So when we talk about preventing heart failure in type 2 diabetes, anything beyond the risk factor control, hypertension control, diabetes control, we recommend diet, exercise, weight loss. Anything else typically that you are evaluating in these patients in clinic?
Exactly. So until now, clinical documents and guidelines really emphasize that core risk factor control in preventing heart failure onset. But now we've had exciting new developments and the discovery of therapies that can actually modify and prevent heart failure amongst patients with type 2 diabetes. And really, it's the class of SGLT2 inhibitors, or the sodium glucose cotransporter 2 inhibitors, that have been shown now in 3 cardiovascular outcome trials, as well as a renal outcomes trial, to prevent heart failure in patients with high-risk type 2 diabetes mellitus.
That's a great point. When we talk about cardiovascular benefit among the newer drug classes, primarily the SGLT2 inhibitors and the GLP-1 agonists, what kind of cardiovascular benefit do we have evidence for currently?
Right. So of those 20 trials, almost every single one evaluated a composite endpoint of primarily atherosclerotic-based outcomes, including non-fatal myocardial infarction, non-fatal stroke, and cardiovascular death. Both classes, the SGLT2 inhibitors and the GLP-1 receptor agonists, have been shown to modify the risk of those major adverse cardiovascular events by about 10 to 15%. And that appears mostly in the highest risk group of patients with established cardiovascular disease. In addition, the SGLT2 inhibitors have been shown to improve heart failure events, as we discussed, and have had exciting reductions in progression of renal disease and protection of the kidneys against future episodes of acute kidney injury. And so both classes of therapy really appear to have broad multi-system benefits across these trials. But I think that the SGLT2 inhibitors particularly have benefits on heart failure risk and protect against renal progression, whereas the GLP-1 receptor agonists appear to modify atherosclerotic pathways primarily and may be especially beneficial in long-term protection against atherosclerotic endpoints.
I think if I remember these trials, when we look at the Kaplan-Meier curves, just like you mentioned, the GLP-1 agonists, you really start seeing the benefit a few months down the line compared to SGLT2 inhibitors, where the reduction in heart failure was probably right away, considering that it is a natriuretic, diuretic, and lowers your blood pressure. So I think that difference also is apparent in some of these results of the trials and the timing of when the benefit is seen.
That's a terrific point.
If we talk about SGLT2 inhibitors in heart failure among patients without diabetes, we've been talking about it for a while, but now we actually have a randomized control trial looking at this. Could we briefly talk about dapagliflozin in patients with heart failure and reduced ejection fraction, irrespective of the presence of diabetes?
Absolutely. So DAPA heart failure, or the dapagliflozin in patients with heart failure with reduced ejection fraction trial, was perhaps one of the most exciting advancements in care in the last several years. This was a large randomized clinical trial of over 4,000 patients with heart failure with reduced ejection fraction. Patients were followed for approximately 18 months on average. They were typical heart failure patients that were well treated on background medical therapy. Over 90% were treated on an ACE, ARB, or ARNI. Over 75% were treated with a mineralocorticoid receptor antagonist. And about 11% of patients were on sacubitril/valsartan at baseline. The trial had really remarkable results with respect to the SGLT2 inhibitor compared with placebo. The primary endpoint of cardiovascular death, heart failure hospitalization, and urgent heart failure visit was reduced by an absolute approximately 5%, from 21% to 16% over that median of 18-month follow-up. And consistent results were seen in individual components of that endpoint, as well as secondary endpoints, with a nominal reduction in all-cause mortality, improvements in health-related quality of life, as measured by the Kansas City Cardiomyopathy Questionnaire. In addition, and perhaps most importantly, there were durable benefits in patients both with and without diabetes. And so this is really the first trial to ever explore the therapeutic benefits of the SGLT2 inhibitor class in patients with heart failure without diabetes. And so I think this is a remarkable advance. I think it will immediately influence how we actually practice medicine. And I think it's going to be imperative that our community implement these therapies appropriately in patients similar to those enrolled in DAPA heart failure.
That's a great point. And like you said, really started thinking about starting this drug on some of my heart failure patients. Of course, there's continued issues on cost, which we'll get into later. One of the things that we've noticed is these medications, especially like you said, sacubitril/valsartan, can have a more significant effect on lowering blood pressure among your patients. So sometimes I have to back off of diuretics in these patients. When you're using this in heart failure patients, is there a role for, or do we need to start lowering some of the other heart failure meds that they're on as well when we're using SGLT2 inhibitors?
It's a great question. And as heart failure care becomes more complex and as we have more therapies that actually have shown important clinical benefits, this question is going to become even more relevant. On average, across heart failure and diabetes programs, the SGLT2 inhibitors have been associated with a modest reduction in systolic blood pressure by 2 to about 4 millimeters mercury. And so on average, most patients can actually tolerate the addition of the SGLT2 inhibitor to background therapy. In addition, there does appear to be volume reduction effects and natriuresis as well as osmotic diuresis with these therapies, especially those with concomitant diabetes mellitus. So I think that up front, often making dose reductions with loop diuretics by about 25 to 50% in stable euvolemic patients with heart failure appears to be reasonable. Importantly, in non-diabetic patients with heart failure treated with an SGLT2 inhibitor, they may not actually achieve as robust natriuresis with these therapies. At the American Heart Association scientific sessions, Professor McMurray will be presenting the non-diabetic subgroup, and I think we'll learn that these patients on average had much fewer adverse events when treated with this therapy compared with diabetics. And as the SGLT2 inhibitors are really downregulated in this population of non-diabetic patients, there's less natriuresis and osmotic diuresis that would be expected. And so for the most part, loop diuretic changes may not be necessary.
Yeah. And to your point where we spoke about these different effects, I think it's important to note that in DAPA heart failure, while they included symptomatic heart failure patients with elevated BNP or proBNP, they did exclude patients with a systolic blood pressure of less than 95 millimeters of mercury or patients that had symptomatic hypotension. So to your point, it's just important just to be careful when you're initiating these drugs among patients who are already on guideline-directed medical therapies for their HFrEF. Yep.
You're absolutely correct. I think taking in the trial eligibility criteria and then when implementing these therapies in clinical practice is really vitally important. And so those exclusion criteria do limit the overall generalizability, but on average, I think most patients can tolerate the very minimal blood pressure lowering of these therapies.
Absolutely. So when we talk about triple therapy in heart failure, we talk about using an ACE-ARB or ARNIs, which are the angiotensin receptor neprilysin inhibitors. We talk about using beta blockers and about using the mineralocorticoid receptor antagonists among almost all our patients that would be eligible for these therapies in HFrEF. We're talking about using quadruple therapy with addition of SGLT2 inhibitors into these three medications. These other three classes have shown some evidence of reverse remodeling among patients with heart failure and reduced ejection fraction. Any evidence for SGLT2 inhibitors also maybe showing benefit with reverse remodeling?
It's a great question. Sequentially, we've learned more about how these therapies actually improve clinical outcomes in this population. Most recently, we learned that sacubitril/valsartan actually promoted reverse remodeling over the course of weeks to months and improved longitudinal LV function and EF improvement. With the SGLT2 inhibitors, many mechanistic studies are underway to further understanding of the composite benefits on reverse remodeling. Most recently, in circulation, there was a small trial called EMPA-HEART CardioLink 6, which evaluated the short-term effects of empagliflozin on LV mass and did suggest net reductions in LV mass with exposure to the SGLT2 inhibitor, suggesting improvements in reductions in wall stress, even over a short duration of time.
So certainly there's evidence accumulating. To that point on how these drugs are working and the mechanistic aspects. Another trial published in Circulation called Define Heart Failure just recently came out, looking at the effect of dapagliflozin on biomarkers, on symptoms, and functional status in patients with heart failure and reduced ejection fraction. What did you think about this trial?
This was a very, very interesting trial, and I think it was very timely as well, as it almost paralleled the release of results of the DAPA heart failure trial, which evaluated the primary clinical outcomes. The US FDA has reinforced that metrics of health-related quality of life and other patient-reported outcomes are potentially approvable on their own if therapies can be shown to safely improve those endpoints. And so Define Heart Failure really evaluated core metrics of functional status and symptoms, and showed with short duration therapy that there are net improvements in validated metrics of health-related quality of life. I think they reinforce the benefits observed in DAPA heart failure, and really show that these therapies not only improve lifespan and improve heart failure hospitalizations, but also have important benefits with respect to health-related quality. Interestingly, this particular trial did not show significant reductions in N-terminal proBNP levels. I think it will have to take these trial results along with other mechanistic results to understand if SGLT2 inhibitors actually influence clinical outcomes via pathways that may be tracked with NT-proBNP. For instance, whether this is really volume reduction, decongestion, reduction in wall stress that predominantly influence outcomes versus potentially other alternative mechanisms, even direct myocardial effects on myocardial energetics.
Mm-hmm. You know, a lot of the stuff we're talking about has come out in 2019. In line with that, the 2019 ESC clinical practice guidelines were also published. These guidelines on diabetes, prediabetes, and cardiovascular disease in collaboration with the EASD. I know we touched upon most of the important points with the newer drugs, but any other highlights from this document that you found interesting?
Yeah, the ESC working group really should be congratulated. This was a very, very rapid update, and included really very contemporary clinical trial information that readily will be used to influence practice. I think the key highlights of the guideline document are that they emphasize early consideration of these two classes of therapies, the SGLT2 inhibitors and the GLP-1 receptor agonists, in appropriately selected patients with type 2 diabetes, with established cardiovascular disease, or who are at high risk for cardiovascular disease. And this is really in line with the clinical trial data. In addition, the ESC guidelines are really the first to depart from the traditional pathway of first introduction of metformin with second line introduction of an SGLT2 inhibitor or GLP-1 receptor agonist. I think this document really recognizes that in high risk patients, the upfront use of these two classes of therapies may most successfully modify outcomes. I think that this does differ from other guideline documents in that, which really are waiting for more core clinical trial outcome data related to metformin. A couple of large randomized clinical trials are underway to evaluate the effects of metformin on primary cardiovascular outcomes. And I think that will help inform the actual sequence of how we use these therapies in practice.
To our listeners, there is these excellent tables in this document. One of these tables that you just referred to really walks you through the different glycemic targets and the different drugs and what to watch out for and when to initiate them. So I would recommend that the listeners who are doing this go to this document and pull up some of these tables, easy to read, use them in clinical practice for initiating and adding on therapies for diabetes care.
I echo that. It was a very practical an updated document.
We touched upon this briefly right at the start. If I remember right, I don't know don't quote me on this, but there is less than 1,000 heart failure cardiologists within the United States of America. We have more cardiologists, but primarily diabetes care is driven by primary care physicians, primary care providers, and all this new information that has come out. How do we optimize our physician workforce to better care for these patients with type 2 diabetes?
It's a great question. Really there's 30 million Americans living with type 2 diabetes. The overall incidence of diabetes is actually declining in the United States, whereas the prevalence has remained steady. And as the burden of obesity and prediabetes increases, we do anticipate a resurgence in rates of diabetes in the community. As you mentioned, in the United States, there are about 23,000 cardiologists, whereas there's relatively fewer endocrinologists, about 8,000, and nephrologists, about 7,500, that are really equipped or poised to care for this burden of type 2 diabetes. And as you mentioned, current care is really dominated by primary care physicians and endocrinologists. I think as cardiologists, we need to enforce early training with respect to cardiometabolic medicine and use of some of these therapies to best implement them. We see patients very frequently in terms of more frequent longitudinal care of these patients. We see them at high risk periods in their life. We see them shortly after myocardial infarction or during hospitalization for heart failure, which may be critical junctures to change therapy and to counsel them regarding modifications of their diet, exercise, and therapeutic regimens. And in addition, purely based on volume and distribution, especially in certain states, cardiologists may be best positioned to actually care for incident diabetes patients. So I think for all those reasons, I think cardiologists should play a larger role in diabetes care as we move forward.
And that's true. I didn't realize that we outnumbered endocrinologists and nephrologists combined. So there's definitely a lot of room for cardiologists to get involved in this care because we really need more physicians getting involved in diabetes care.
That's right.
I know we spoke briefly about the renal benefits, but the renal benefits that we see with SGLT2 inhibitors is relatively unique to this class of medications. And would you say that this is a class effect and it has maybe acute and chronic benefit both?
Yes, this was actually one of the dramatic multi-system benefits that were observed in the clinical trial programs. A nice meta-analysis of all clinical trials conducted to date of the 3 cardiovascular outcome trials as well as a dedicated renal outcomes trial showed that the SGLT2 inhibitors not only prevented need for dialysis, transplantation, or renal death, but also protected the kidneys against future episodes of acute kidney injury. Importantly, these therapies benefit patients across a range of eGFR and benefit patients across a range of albuminuria, and the benefits are present even in the background of complete blockade with renin-angiotensin system inhibitors. So I think that the findings are robust. They do appear to be a class-wide benefit with very limited heterogeneity seen in these meta-analyses across the randomized clinical trials. And now, very similar to the heart failure programs, now there are dedicated trials that are evaluating SGLT2 inhibitors amongst patients with chronic kidney disease with and without diabetes. So we're going to learn a tremendous more about the class and their effects on renal health.
Like you said, so no conversation is complete without the expense aspect of things. And the healthcare costs in this country with heart failure, as we know, are several $billion dollars, and diabetes care also fairly significant. The cost aspect of these newer drugs, in your experience, have you found prescribing these medications to be fairly expensive, and any added cost burden for patients from these newer medications?
Yes, of course. On an individual patient level, there are always going to be added cost burden with especially newer therapies. I think as a society, we need to understand and we need to attempt to tease apart whether that added cost does allow for either cost effectiveness or even cost savings when we take into account the downstream benefits of reductions in hospitalization and life prolongation. So when considering, for instance, the SGLT2 inhibitors, the wholesale price for a month of therapy is about $500. And various insurances have differential coverage of these therapies. On average, patients would still be anticipated to pay some out-of-pocket expenses, which surely does influence their overall adherence and their willingness to get on therapy. So it's an important consideration. Clinicians should definitely be aware of the cost paid by individual patients. But it's also important to recognize that newer heart failure therapies, including ARNI and including SGLT2 inhibitors, may be more costly, but when implemented in the right patients and in appropriately selected patients, have been consistently shown to be cost effective and in certain settings, even cost saving. Dr. Greg Fono and others have really promoted the concept that effective implementation of quadruple therapy may allow for longitudinal reductions in all-cause mortality, affording a net number needed to treat of only 4, which is really dramatic and is unseen in any other discipline of medicine. So I think as a society, given the burden of heart failure, the cost implications of heart failure care, I think we need to be committed to allowing and promoting affordability amongst patients to get them on these therapies. These are life-prolonging therapies. They modify disease course and need to be implemented. So I think we need to take a concerted effort to do that.
And as part of this quadruple therapy, considering there could be significant variability among different physicians involved in practice, what do you think is the role for having guideline-directed medical therapy titration clinics and, capturing these patients, getting them into a standardized protocol for this, probably run again by multidisciplinary care providers? Do you have any experience with maybe these clinics, and what's your view on them?
Right. So as the burden of heart failure grows globally, there's an increasing number of physicians and specialists that participate in their care, introducing potential variability in diagnostic approaches or care quality. And so while much of the investment of heart failure medicine has been in acute care needs and end-of-life care, our next phase of investment really needs to be around the effective implementation of this now background quadruple therapy. Heart failure stands unique, as I mentioned, that we now have several life-saving therapies, and busy clinicians, however, may not have the time, bandwidth, or resources to optimize care during short ambulatory care visits. So dedicated guideline-direct medical therapy clinics, which are being implemented now across the United States and worldwide, may best fill this gap. And as we move towards value-based models of care, these systems may be most readily reimbursed with complete introduction of evidence-based therapies, and maybe the best way to keep patients living longer and healthier.
Mm-hmm.
So as we envision it, these guideline-direct medical therapy optimization clinics really are multidisciplinary. They include physicians, they include advanced practice providers, they include clinical pharmacists, and clinicians may actually refer to this centralized clinic from many settings. For instance, urgent care, emergency departments, even the hospital setting. And patients may be optimized on therapy and then continue to be longitudinally followed by their usual care providers.
Another aspect of these therapies is women are usually underrepresented in a lot of our heart failure cardiovascular trials. Is there a difference in response to the heart failure therapies between men and women?
It's a great question, and I think it's increasingly becoming the forefront of our attention. As we understand more about heart failure, especially heart failure with preserved ejection fraction, it appears to be a syndrome that affects more women than men, and we may need to be more mindful of sex-specific therapies. Paragon Heart Failure really enrolled the most women of any heart failure trial conducted to date. And interestingly, the trial, while overall showed only modest benefits with respect to heart failure hospitalization and cardiovascular death, showed pronounced benefits in the large subgroup of women compared with men. So as we further dissect the trial and understand this finding, I think it reinforces that heart failure therapies may act differentially in men and women. There was an interesting manuscript in Lancet that evaluated differential dosing of therapies in men and women and did suggest that women may require lower overall doses compared with men in clinical practice to actually achieve very similar clinical effects. And so I think that another major challenge as we move forward is dissecting this sex-based differential in therapeutic responses.
Mm-hmm. I apologize for just going a little over time. So I'll touch base on the last few topics with you. There's a huge conversation, and patients have been asking me this question on different diet patterns that they can safely do in diabetes and in those with cardiovascular disease, prior myocardial infarctions, and heart failure. What is your opinion?
Yeah, despite the really central importance of diet and cardiovascular health, nutrition science has really lagged behind much of the investment that we've had in understanding benefits of cardiovascular therapies. I think that there have been several new diets that we've seen in clinical practice. Much have not been rigorously studied in the setting of randomized clinical trials, and certainly little is known about the long-term clinical outcomes related to these diets. I think ketogenic diets especially are important for all clinicians to better understand since patients are increasingly adopting them. However, it's also relevant to recognize that while they may have favorable metabolic benefits, in certain circumstances they may actually pose risks. And for instance, when used in patients who are treated with an SGLT2 inhibitor, they may actually exaggerate ketosis and risk for euglycemic diabetic ketoacidosis. And so I actually recommend patients who are treated with an SGLT2 inhibitor to avoid or at least limit ketogenic diets, and if they must be on a ketogenic diet, to interrupt therapy with an SGLT2 inhibitor.
Yeah, and like you said, the 2019 ESC document also really recommended reduced caloric intake and maybe a Mediterranean diet in some cases. So it didn't really feel like they needed to comment on specific diet patterns beyond these, which, as we know, have some benefit for cardiovascular disease. Do you see a role for SGLT2 inhibitors in patients with HFpEF or those with mid-range ejection fraction? I guess those are the ones between 40 and 50% EF.
Yeah, so the SGLT2 inhibitors are now being studied in the large group of patients with both mid-range and preserved ejection fraction. Two large randomized clinical trials, Emperor Preserved evaluating empagliflozin and Deliver evaluating dapagliflozin, are now underway, are expected to report either next year or in 2021. So I think we're going to learn a lot more about how these therapies actually influence cardiovascular risk in heart failure with preserved ejection fraction. Until then, I think in diabetic patients with heart failure with preserved ejection fraction, they may be cautiously introduced with the usual caveats that these trials are underway. We'll learn more about them very soon.
One of the questions that's a little off topic maybe, but still pertaining to heart failure patients, are you using the angiotensin receptor neprilysin inhibitors among patients with heart failure and preserved ejection fraction or any specific subgroup of those patients?
It's a very relevant question as we heard the landmark findings from the Paragon heart failure trial presented at the European Society of Cardiology. Novartis is expected to submit a sacubitril/valsartan for regulatory review for an indication for heart failure with preserved ejection fraction based on the composite benefits observed in Paragon heart failure. Until that process of review is underway and complete, I personally have not used ARNI as an off-label therapy in heart failure with preserved ejection fraction. And I suspect this step will be actually critical before payers and clinicians will actually use them in practice. So I think the central message is stay tuned. Again, we'll hear more from the regulatory review very soon, and see if this is actually added to the label for use and extend the label beyond heart failure to reduce ejection fraction.
Should I, as a cardiologist, now start changing some of these diabetic meds among patients? And maybe if I see someone on drugs that have not been initiated because of lack of conversation or lack of awareness in the community, should I maybe go back to the primary care providers and recommend or suggest starting some of these newer drugs in my cardiovascular patients, in my heart failure patients especially?
Yeah, there's no question that primary care physicians will continue to play a major role and really drive diabetes care. However, cardiologists, as mentioned, frequently encounter high-risk patients with diabetes, and those who appear to stand most to benefit from these newer classes of therapies. So I think at the end of the day, I believe that specialists and generalists should become readily familiar with the use of these newer classes of therapies. SGLT2 inhibitors and GLP-1 receptor agonists are now being studied for much broader indications well beyond diabetes and are poised to become key therapies for overall cardiometabolic care. So my short answer is yes.
Thank you so much for your time. Any last comments? Anything else you want to tell our audience?
No, I just want to thank you for inviting me to participate and hopefully covered useful information for the listeners. And again, another plug for academic Twitter, which I think has been a tremendous repository of a lot of the information we covered to help keep up with the rapid pace of science around cardiometabolic medicine.
Yep, no, I've been following you on Twitter, and that's how I keep up with some of the diabetic stuff that's going on. What is your Twitter handle for our audience, just so that they can find you and maybe, use you as a resource for getting some of the latest updates?
Absolutely. So it's M and then my last name, Vaduganathan. So it's M, V as in Victor, A, G as in dog, U, G as in George, A, N as in Nancy, A, T as in Tom, H, A, N as in Nancy.
Perfect. Thank you so much for your time.
Really appreciate it. Thank you.
I wanted to end this episode by discussing a randomized control trial that was recently released just 2 weeks ago in the European Journal of Heart Failure, which showed safety of using SGLT2 inhibitors on decompensated heart failure patients and starting this medicine inpatient. So it's the randomized, double-blind, placebo-controlled, multi-center pilot study on the effects of empagliflozin on clinical outcomes in patients with decompensated heart failure. It's the EMPA Response AHF study. This was a randomized, placebo-controlled trial which randomized 80 acute decompensated heart failure patients with and without diabetes to using either empagliflozin 10 milligrams per day or placebo for 30 days. The primary outcomes were change in visual analog scale dyspnea score, diuretic response, change in NT-proBNP, and length of stay. They included some other secondary outcomes, which were basically safety and clinical endpoints. The study was concluded as showing significant evidence for safety in using this within decompensated heart failure patients within 24 hours of hospitalization using the dose of 10 milligrams per day empagliflozin. They did exclude a lot of patients from this study, and that can be told by the fact that almost 900 patients were evaluated for eligibility within the study, and only 80 ended up getting randomized, 41 to getting the drug, 39 to getting placebo. A lot of patients were excluded, main reasons really being the indication not being decompensated heart failure for admission, really no dyspnea at rest or minimal exertion, really no evidence of congestion, patients not getting loop diuretics, patients having a GFR less than 30, patients with type 1 diabetes in cardiogenic shock with a recent ACS or a recent planned intervention. Also patients who had a history of ketoacidosis. So a lot of these patients were excluded. In patients with acute heart failure, treatment with empagliflozin had no effect on change in visual analog score dyspnea, diuretic response, NT-proBNP, and length of hospital stay, but was safe. It actually increased urine output production and reduced the combined endpoint of worsening heart failure rehospitalization for heart failure or death at 60 days. Relatively small trial, really no concerning adverse event profile. Important to note that 92 to 97% of the patients, depending on which group you look at, had NYHA class 3 to 4 heart failure. And the mean EF in this study was 36% with standard deviation of 17%. So included both reduced and preserved ejection fraction. Patients were old, on the mid-70s. If you look at the mean age, a third of them were women, almost entirely Caucasian population. The blood pressure at initiation, the mean blood pressure was in the 120s. These were not patients who were hypotensive. There was clearly an evidence for increased urine output when SGLT2 inhibitors were combined with diuretics. So more data to come, but very promising early data, and shows that it's safe to start these medications in hospital within 24 hours of presentation in these relatively sicker, older heart failure patients.
If you enjoyed our episode, don't forget to like, subscribe, and give us a high rating, as it helps other listeners find us. You can leave your suggestion for topics, critiques, things you think we can do better. You can email us at heartsuccessteam@gmail.com. You can actually find us on our website at www.heartsuccess.info. Our website now also provides links to all the podcast providers where you can listen to this episode. You can find us on our Facebook page at Heart Success Team, or you can always reach me on Twitter at CardioBro.